Hi everyone, welcome to our fourth journal club in Psychiatry Network, and I have a surprise for you guys today because I have our guest speaker here in my home, and I'm gonna turn the camera in a moment to show him to you, but this is, tonight we have Dr. Pradeep Thapar, and he is a psychiatrist actually in the same area that I live and work in. He lives probably 5 minutes away from me, and he has a couple of offices around here. And so Dr. Thapar has actually been in practice almost 30 years in the west suburbs of Chicago. He is an attending psychiatrist. He practices adult psychiatry. He's also child board certified, but he does all kinds of other things like geriatrics and addiction psychiatry, which I know are always people are always asking me for referrals in this area for both of those, and so it's always good to have another referral. And he's also the medical director at Metro South Hospital, which is in Blue Island here in Illinois. And his two outpatient offices are in Orland Park and Chicago Ridge. And so he has very kindly come to my house for the first time with one of these videos. It's nice to have the guest in person and not on the other camera. And he's going to be presenting our topic today, which is it's called, I'm going to just peek at his article, The Comparative Effectiveness of Clozapine and Standard Antipsychotic Treatment in Adults with Schizophrenia. And this is Antipsychotic Week. Last week we did two addiction topics, and this week we're doing two antipsychotic topics. So Clozapine is the first one, and I did put more detailed directions up at the top of this post for how to access the CME, and I have to say I've been getting a lot of messages through Facebook, through email, etc. And I'm a little bit backed up, so if I haven't responded to you, don't worry. In the next couple of days, I'm going to respond to you and get you set up with the free CME sponsored by the American Physician Institute. And yeah, just with any questions, feel free to email me. And if you want to get added to our mailing list, it's psychiatrynetwork@gmail.com. Just send me a message over there and I'll add you. So I'm a little bit behind in those additions as well, but I have everything. It's like very organized. Just put the word subscribe in the subject and I will get you added. And so without further ado, we have Dr. Thapar. So I'm going to just turn the camera so that it's facing him, and he's going to take it away. Thank you so much for joining us.
Hi, good evening, everybody. I'm Dr. Thapar. I'll do my best to do the article today. So this is our fourth, journal club today, and this article is Comparative Effectiveness of Clozapine and Standard Antipsychotic Treatment in Adults with Schizophrenia. So, Clozapine has been a very, commonly used drug, but not also very uncommonly used drug. We have not been using it. So what they have done in this article is they have, compared the effectiveness of initiating treatment with Clozapine or a standard antipsychotic among adults with evidence of treatment-resistant schizophrenia in routine clinical practice. So the method was they had chosen 3,123 patients, and they were all Medicaid patients from 2001 to 2009. And the primary outcome was hospital admission for a mental disorder. And the secondary outcome included discontinuation of the index antipsychotic, use of an additional antipsychotic, or incidence of serious medical conditions, and the mortality. So what they found in the article is that there was a decreased rate of psychiatric hospital admissions when we used Clozapine versus the regular antipsychotics. But Clozapine, as we know, is also associated with significantly increased incidence of diabetes mellitus, hyperlipidemia, and also intestinal obstruction. So in the article conclusion was they concluded that in the adults with schizophrenia and evidence of treatment resistance, Clozapine compared with a standard antipsychotic was associated with greater effectiveness on several important outcomes, increasing the judicious use of Clozapine, and it was a much better antipsychotic that we have not been using in our practices. Like we all know, schizophrenia is about 1% of the population, and when we give them an antipsychotic, in about 30% of patients obtain no relief or very little benefit from the antipsychotic medications. And clozapine actually has been widely available for decades and remains the only medication approved for treatment-resistant schizophrenia. And we all know that it also decreases suicidal behavior, but the negative side is it has increased risk of air granulocytosis. So, in a small practical trial, in the past, McConvey and, colleagues reported that, people who had, discontinuation and we gave them, clozapine, versus, Risperdal and the Seroquel, they had a much better response with the clozapine, but not with the Zyprexa. The response with clozapine was much robust. And there was another research done in Finland, and they also said that clozapine was associated with the longest time to treatment discontinuation. That means the patients did not stop the clozapine, because the other antipsychotics people stop very easily because the response was much robust with the clozapine. So it was a randomized, controlled trial. And like I said, they had the Medicaid patients in there. They were from ages 18 to 64, and they all were diagnosed with schizophrenia, and they had taken at least one prescription antipsychotic and they had failed it. And so they were initiating clozapine or Clozaril for these patients. So what they excluded people who had lack of prescription for other antipsychotic, they did not take them. People who had, medication possession ratio, or they have not taken medication for a year, who were never in a psychiatric hospital for a year, they also discontinued them, in the study, and they had other diagnoses. Or they had, lack of prescription and they have taken 2 standard antipsychotics, so they, basically excluded them. So, like I said, the patients were all Medicaid patients between the ages of 18 and 64, and they were enrolled in the Medicaid program. But if somebody was in Medicare, they excluded that. And, a new antipsychotic was one for which there was no filled prescription in the prior year. So they have taken like one antipsychotic, but then they were now using the clozapine for that. The only negative side with clozapine that they found was it gives you a neutrophil, count which goes down like we do the, standard, checking of the WBC counts. They had myocarditis and they had malignant neoplasm and seizure disorder and Alzheimer's disease. So anybody who had any of these disorders like a neutrophil number function, disorder, or a myocarditis, or a malignant neoplasms, or a seizure disorder, or Alzheimer's dementia, or a degenerative brain disease, they were all excluded. And they only took patients who were just pure schizophrenic who have taken one antipsychotic and they were now not responding to it. Any patient who had taken a long-acting injectable antipsychotic for the last 60 days was also excluded from the study. And so it was a very pure study in which they had very strong indicators there. So as we see here, they, if you see table 1 here, they had clozapine patients versus other antipsychotics, and they had a whole, different variety of patients between race and ethnicity. They had the Medicaid eligibility, they had schizophrenia subtypes, they had taken medications in the past, and then they had other mental illnesses. So they actually compared, head to head, patients with clozapine versus patients with other antipsychotics. And outcome measures were that psychiatric hospital admission was the primary outcome measure. So they are basically checking and seeing when they gave a patient, who they were, in the study, clozapine, were they going back to a psychiatric hospital as an inpatient. So that was the primary, measure. And the secondary effectiveness outcome were discontinuation of the index antipsychotic. So what basically they're saying is, if they were discontinuing their medications, so they were comparing, clozapine use for the patient versus another antipsychotic and seeing what the discontinuation rate for that was. And the safety outcome was also, measured in that. So that was the study. So they also used, 2 statistical methods here. If you look at table 2, where they have, psychiatric hospitalization, Clozapine versus the standard antipsychotic. They had 981 patients versus 1136 for a standard antipsychotic. So it's a very, comparable study where they had, very equal number of patients between the clozapine, study and the standard antipsychotic study. And the propensity score was calculated among, in patients who had some kind of regression, and the patients were receiving clozapine versus a standard antipsychotic based on a broad array of demographics, clinical and mental health service utilization from the max data that they collected. So if you look at the table 2, you will see all of that. Then they had, there's another study where they had the Cox proportional hazard methods they were used here. And they did the same kind of analysis where they were comparing, clozapine with the, standard antipsychotics. So if you look at the summary and the results, they said during the year following treatment initiation, patients receiving clozapine had more outpatient visits for a primary diagnosis of schizophrenia. That means they are coming to a doctor as an outpatient, but not going as inpatients, which was the study. They wanted them to not be hospitalized. And so they were coming to doctors, on a very regular basis to have their outpatient visits for a primary diagnosis of schizophrenia, which is for which we are studying here. And they were coming for more psychotherapy visits also. If you look at table 3, they have done the same thing here. They have compared the cohorts of clozapine versus the standard antipsychotics. In the primary outcome analysis, patients initiating clozapine had lower rates of hospital admission for a mental disorder than patients initiating other antipsychotic medications. Patient initiating clozapine also had lower rates of discontinuation of the index antipsychotic medication. So this was a very important, factor that we are, seeing here. Also, patients initiating treatment with clozapine had a significantly increased incidence of diabetes mellitus, which is a hazard for us, hyperlipidemia, and also intestinal obstruction. So basically, clozapine was helping for hospitalization, but we have to really watch what they're telling us for diabetes mellitus, hyperlipidemia, and also intestinal obstruction, which I didn't know was the case with clozapine. I've never heard intestinal obstruction. I always thought clozapine caused more, sialorrhea or, seizure disorder and also a lower count. But this, study also found that they had more, intestinal obstruction. I'm sorry. There were no significant group differences in the incidence of self-injurious behavior. So, like some patients of ours, are like, cutters, and they come to us with also psychosis, but that was not a difference in the study, where the clozapine versus the standard antipsychotics. There was no difference between, venous thromboembolism, but the number of cases of myocarditis, agranulocytosis, and ischemic heart disease each fell below 11, which was the smallest number that we saw in this one. So in the discussion, we see here that initiating clozapine was more effective than a standard antipsychotic on a risk of hospital admission, antipsychotic discontinuation, and initiation of a new antipsychotic medication. And in this one, they saw that when they initiated the clozapine versus the standard antipsychotic, 12.7% of patients with schizophrenia in the Medicaid group who were treatment resistant had a lower rehospitalization as an inpatient. But they issued a warning for the clozapine, like I already said, that we have to watch between myocarditis, agranulocytosis, and also it is likely to elevate their counts. Their incidence of obstruction, and also the warning of the counts that we have to watch very closely. So that's the only negative that we see in this one. If you look at the conclusion of the study, they see that the patients with schizophrenia and evidence of treatment-resistant initiating clozapine was more effective than initiating a standard antipsychotic medication. Clozapine was associated with lower rates of psychiatric hospitalizations, index treatment discontinuation, and use of additional antipsychosis or antipsychotics. So the only thing that we have to really watch was clozapine did cause an increased incidence of hyperlipidemia, diabetes mellitus, and interstitial obstruction. But the results strongly support that efforts to increase the judicious use of clozapine should be something that we have to think as physicians and who do inpatients and also outpatients, because I think it's a medication which is not very much popular amongst us physicians as psychiatrists.
Yeah.
And we don't use it very much. I don't use it very much, only in case where I've failed all antipsychotics. So this study really tells us that we should think of it as our second choice after one antipsychotic fails. But we do have those negatives, like I pointed out. But clozapine also decreases the suicidal behavior, and I think it's a unique medication in our community practices, where we should really think of clozapine as something that we should be using it. So the study basically is emphasizing that, and I think they have shown it very nicely that it's a medication that we should be very closely or we should think about it as something that we could use.
Thank you, Dr. Thapar. We did have one question, which was, did they do blood levels, pharmacy records, or self-report for the discontinuation rates?
They did not mention in the article if they did the blood reports, but I'm assuming, the Sandoz, which is the clozapine maker, you have to do the blood levels. You cannot, they would not let you do, or they would not let you use the clozapine because unless you are in the Sandoz program. So the article does not mention that, but I'm assuming as a psychiatrist, using clozapine for about 27, 30 years, that I'm sure that was the case, because you cannot use clozapine otherwise.
Okay, very good. And thank you so much for presenting this article. Here, I'm going to just scoot the camera back a little bit. But I agree. I think clozapine is underutilized by us as a specialty. I know that the recommendations, I'm going to just pop my head in. The recommendations have been that if you fail 2 antipsychotics, really your next step should be clozapine. And I know that many of us, myself included, I'll say, are afraid to go to clozapine because it's, first of all, it's a little bit difficult to use because of all the restrictions and the registry and the levels and all of that. So, but also we're very concerned about the side effects. But it's really, I think one of the things that I learned from hearing about this article today is all the benefits of clozapine, and specifically, which things it can improve, and some of the outcomes for post-hospitalization admissions and things like that come with using clozapine versus another antipsychotic. So I really appreciate having heard about this topic. So do you have any other take-home points or just anything else you want to mention?
I think we should really think about this, me included, because we always keep on changing antipsychotics. I change several atypicals, and sometimes I've done a combination of antipsychotics also in my practice, right, where I use a typical with an atypical. But I think when I read this article, I said to myself, why not use clozapine as your second choice when you fail one antipsychotic? So something for all of us to use and think about and maybe implement in our practices.
Yeah, very good. And of course, reading this article, if you're doing the pilot project, this is one of the articles that you can read and answer the ABPN questions starting January 1st. But in the meantime, feel free to go to the link at the top of this post and claim the free CME. You get 0.25 credits of CME for each journal club video that you watch. These are 15 minutes long. We keep them short and sweet. And again, Dr. Thapar was so lovely to come to my house. He brought me dinner, such a nice gentleman, and to present this article for us. So thanks, guys, and we will see you Wednesday night at 7:30 for the next journal club. All right, have a good night.
Thanks, everybody.
Bye.